become an annual event. It's a very, very useful course for all postgraduates. And I think a lot of knowledge is packed into it for 2 days. I heard Dr. Prakash Shastri. I learnt myself a few tips from him. And I think this is very important from the exam point of view also. The curriculum also has been reviewed from that point of view. I'm going to talk about ECMO and ECCO. Let's see if this works. No, it doesn't. Okay, so this is, I had hosted the SWAC also conference a few years back, and you can recognize most of the people. And the third guy from the left is the inventor of ECMO, Robert Bartlett. He's still very active. He's a cardiac surgeon. So what is ECMO basically? A lot of people have started doing it during the COVID times. Well, basically you support the heart or the lungs or both. So if the heart is failing or whatever reason it may be, I'll come to that more in detail, then you need a VA ECMO. If only the lungs are failing but the heart is okay, you do the VV ECMO. So that's Robert Bartlett in his younger days. And this is the history of ECMO. So basically Robert Gibbon was the started artificial oxygenator. And Bartlett did it in 1975. This was a Mexican immigrant lady who delivered, who had a child who had a meconium aspiration, and he put her on a ECMO, and this was the first lady who survived, and she is also a mother of a proud mother of a kid now. And this over the years, you can see the number of cases have been going up, and the results have also been improving. So worldwide, the large numbers are done now. What are the indications? As I said, cardiac failure or respiratory failure. It should be potentially reversible. Don't put it in a terminal patient. And obviously, you have to weigh the risk-benefit ratio. Particularly in India, because of the economic constraints, you have to be aware and you have to discuss with the family before you put the patient to the ECMO. So VA ECMO, what are the indications? Basically cardiac support. Commonest was the acute coronary syndrome with mechanical complications like ventricular septal rupture or acute mitral regurgitation, cardiogenic shock, myocarditis, which may be any reason, viral myocarditis or drug-induced myocarditis, massive pulmonary embolism, cardiac trauma, anaphylaxis, refractory shocks. One of the common reasons is post-cardiotomy. Patient is not able to come off cardiopulmonary bypass. Cardiomyopathy, bridge to transplant, cardiogenic shock, chronic ventricular failure. And what are the indications for VV ECMO, which is a respiratory support basically? ARDS, whatever the etiology may be, but it should be reversible pathology. That's the important thing. And commonest we find bacterial and viral pneumonias. In COVID times all were viral pneumonias, even aspiration pneumonia, alveolar proteinosis, and the patient waiting for lung transplant. Most of our lung transplants which we do here, many of them are done on ECMO. When you should not do it, any procedure which you do, you should know when not to do it. More important than when to do it. So when you not to do it, when it's a terminal illness, patient is not going to survive. He's got uncontrolled hemorrhage because these are patients you're going to give blood thinners, they can start bleeding. Very old patient also one would avoid. Relative contraindications, if ARDS has been for more than 7 days, then the possibility of recovery are not that great. Irreversible, cerebral hemorrhage or stroke or something, then there's no real point in doing it. Very old patient, morbidly obese patient, and so on. So these are some of the contraindications. Obviously, you have to take into consideration the social and financial constraints of the family. How long can you keep it going? Because once the patient is put on ECMO, you are supporting the vital organs and the patient can go on for a long time. I've kept patients alive for 3 months. 2 of my patients were for 3 months on ECMO. And then the problem is, what do you do? If the patient is not moving any further, can you withdraw ECMO? That becomes a difficult question to answer. Fundamentally, what are the structures involved in this? Is you have a pump because you require pressure to pump the blood. Okay? I will not, there's a venous line which drains the blood, deoxygenated blood, the pump which pumps it, and this is the oxygenator which oxygenates and removes the carbon dioxide. Simple, it does the function of the lung. And obviously, when there is a function, the lung structure which is functioning like the lung, you require oxygen flow to blow off the, you oxygenate the patient and blow off the. So there is an air mixture and an oxygen supply, and then it is pumped back into the patient. You require probably a filter also. So what does it do? As I said, it drains the venous blood, it facilitates oxygenation, removes the carbon dioxides. In VA ECMO, it under pressure, so it will take over the function of the heart. So it will, under high pressure, it will pump into the arterial circulation, it delivers oxygen, removes carbon dioxide. What determines the oxygen delivery capability? Obviously, blood flow will decide that. Hemoglobin concentration, hemoglobin saturation, which is the inlet, how desaturated the blood is, and obviously the artificial lung, the properties of the artificial lung. Over a period of time, the efficacy goes down, and therefore you may need to change it. Carbon dioxide removal is determined by basically the blood flow and the gas flow. So these are the ones, like ventilation, you adjust your gas flow in the ventilator. So that is what the gas flow does that. And obviously inlet carbon dioxide. If the PCO2 is very high, then obviously removal will not be that good. And obviously quality of the membrane lung. And then there are tubings which connect and drain the patient. And there is obviously a pump. The earlier days it was a roller pump which squeezes the blood, the damage to the blood is more. Nowadays there is a centrifugal pump, which is a very high speed, it rotates at 4,000 RPMs, and it can last, the oxygenator can last nowadays for 21 days. And this is what the oxygenator looks like. It's a hollow fiber oxygenator. Efficacy is very good. It can work for 21 days. How is it different from standard cardiopulmonary bypass? Some of you may be from anesthesia background or may have seen cardiac surgery being done. We do most of the surgeries on heart-lung machine. So basically, the oxygenator is much more efficient. The damage, so the cardiopulmonary bypass normally is 6 to 8 hours is what we use it for. This one, the oxygenator is much more efficient. The damage to the blood constituents is much less, and the pump is centrifugal pump, not the roller pump. Okay. And polymethylene pentene oxygenator is used, which is less damaging. So these are the classic two diagrams of the VV and VA ECMO. VA, as you can see here, the deoxygenated blood is taken out from the right atrium or the femoral. Yeah. So it's taken out of the, so it's draining the blood from there. It goes to the pump, which oxygenates, and then the oxygenator, so it oxygenates the blood, and it is pumped back under pressure into the arterial circulation. That's what it does. It takes over the function of both the lung and the heart. On the other hand, for VV ECMO, you have a cannula into the right atrium, and you have a cannula into the commonest is interjugular vein. So you drain it from the right atrium there, through the femoral road. Again, the deoxygenated dark blood comes through the pump and the oxygenator, and oxygenated blood is pumped back into the venous circulation. So obviously there is some mixing of the blood, so the oxygenation may not be that efficient, but it's good enough for that. When do you use this to see, if you have a bad lung, but you have a good heart, you use a VV ECMO, okay? And you can use a central ECMO also if your chest is open. If you have a good lung, but bad heart, then you need a VA ECMO. If you got both, then obviously you need a VA ECMO. Okay, this is a VV ECMO single cannula. This is a single cannula. So one cannula, the cannula tip, which is goes into the IVC, the junction of the right atrium and the IVC there, lower part there, and it oxygenates, and the oxygenated blood is pumped back into the interjugular vein. Okay, so the mixing is not as much. And this is a VV ECMO 2 venous cannula. You put two separate cannulas, one into the through the femoral vein. The second cannula can go into from the interjugular vein. There are two cannulas, the venous cannulas. This is a single cannula, or you can put it into the femoral long cannula into the right atrium. Is that clear? Yes? Okay. And when you check on the X-ray or with the ultrasound, whatever you do, the gap should be around 10 to 15 centimeter, about 15 centimeter between the two venous cannulas, here and here. So about 15 centimeters here, you can measure it, because if they are too close, there will be too much of mixing of the blood. I'll come to that a bit later. So you need to check that once you put your lines in. Normally, venous drainage of 22 to 30 French cannula. Return cannula is about again 15 to 23. And the dual cannulation 27 or 31. And this is a VA ECMO peripheral circulation. That means arterial cannula would be put through the femoral artery, and then for the pressure, for the drainage, you put the femoral vein, and arterial cannula can be put into the femoral artery, or it can go through the subclavian in children, or it can, even small children, it can go through the interjugular vein into the carotid artery. Okay, so basically you are draining the venous system and pumping it back into the arterial system. Again, VV ECMO, what are the indications? Hypoxemic respiratory failure or hypercapnic respiratory failure. So basically, your PF ratio should be pretty low, less than 150, at a high PEEP and 90% FiO2. You're still not maintaining your peak pressure, you're still exceeding plateau pressure more than 30 centimeters of water. And obviously, as a bridge to transplant, you can use it. Second is hypercapnic respiratory failure. The patient is remaining acidotic despite adequate ventilation. PCO2 is more than 80, pH less than 7.1. So this is the classic diagram which all of you would remember, graphical form of management of ARDS. So how does one begin? For mild ARDS, you give oxygen in different forms, HFNC or humidified oxygen. Moderate ARDS, then you ventilate the patient with a low ARDS network ventilation. I will not get into that. You increase the PEEP over a period of time, still doesn't work. Severe ARDS, patient remains hypoxemic. Murray score is high. Prone positioning you have tried, not working. That is the time for refractory hypoxemia. You put patient on ECMO. There are two trials which you people must remember from the exam. One is the Caesar trial, which was done in UK. All the patients prospectively who had severe ARDS, not oxygenating adequately, were transferred to this hospital, Glen Eagles Hospital in Leicester, in UK. And then they were divided into two groups. Half the patients were put on ventilator, conventional ARDS network ventilation. Half the patients were put on ECMO. So this was the indications. It was a multi-center trial. Patients were either airlifted or by road they were transferred. Adult patients, Murray score more than 3, severe ARDS. I will not describe Murray score, I think it is easily available anywhere, but Murray score should be more than 3. So this was 766 patients, 90 and 90 were randomized to two groups. So what did they find? There was no significant difference in the mortality, but basically they recommended the patients with severe ARDS can be managed in a tertiary care center better than in a peripheral center, which is a given. But there are additional benefits. There are faults in the paper. I mean, I will not get into details of that, but not every patient who were designated to a group stayed in that group. That means only 75% of the patients in the ECMO group brought ECMO, actually. So there were, and patients were not ventilated, all of them, according to the ARDS network recommendations. So there were flaws in the thing, but it was a positive study, not from mortality point of view, but patients should be managed in a tertiary care center. The second classic paper, which you from the exam point of view must know, is Alain Coombs' this Eolia trial. Okay, this was a randomized large French trial. ARDS network, patients all were ventilated according to the ARDS network, so that thing was removed. Patients were on a ventilator for less than 7 days. PF ratio less than 50 for 3 hours or PF ratio less than 80 for 6 hours. And patient remained acidotic and PCO2 was more than 60 for 6 hours. With the respiratory rate increased to 35. Despite that, patient remained hypercapnic and acidotic. And crossover was allowed. If somebody was not doing well in the control group, then they were allowed to be put on a ECMO. Again, mortality was 35% in ECMO and 46%, it was statistically not significant. But what were the additional findings? The primary endpoint was not met. Okay? But the secondary endpoint, which was significant, was lower risk of treatment failure in the ECMO group, lower risk of renal replacement therapy, less proning required in ECMO group, more severe thrombocytopenia, more bleeding events, less ischemic events in the ECMO group. So this study did suggest possibility of benefit. I will not get into strengths and weaknesses. I've already covered part of that. And over a period of time, as you can see, not only the number of cases are going up worldwide, but the mortality is also getting much better. Survival for VA ECMO slightly lower, is about 40 to 45%, and for VV ECMO is about 60% mortality, survival. How does one set initial setting? Well, like a ventilator, when you put the patient on 100% oxygen, so blood flow should be 60 to 80 mils per kilo. Maintain saturation 88 to 90. You do not need to maintain higher than that. Sweep flow, that is the gas which is flowing into the oxygenator at around 7 to 10 liters, and you start with 100% FiO2. Okay. What does one need to monitor? Additionally, you need to monitor pre-oxygenator pressure and post-oxygenator pressure. Okay. And the pressure differential should not be more than 50 millimeters of mercury. And the pre-membrane pressure should not be more than 150, because if the oxygenator is not working, the partial thrombi in it or whatever, then the pressure will increase, the pressure gradient will increase. So you have to keep that in mind. When pressure gradient is increasing and the pre-oxygenator pressure is increasing, that means requiring more pressure to pump the blood, you require to change your oxygenator. Also look at your coagulation parameters. What additional thing you do? Checks X-ray, daily bloods, urea, creatinine, KFT and all that you'll do. Anticoagulation, you have to do APDT twice a day, otherwise 6 hourly or 4 hourly you do ACT. We normally keep a bedside ACT monitor. Obviously you need to monitor fibrinogen, not daily but alternate days, and plasma-free hemoglobin should be kept low, otherwise renal failure will increase. Blood culture routinely are done about 3 times a week. What do you want to the ventilator? Well, ventilator you give rest setting. You want to rest the lungs. That is the whole idea. Okay. So plateau pressure should be less than 25. Normally respiratory rate is kept around 10, and high PEEP. You keep about 10 to 15 PEEP to keep the lung inflated, but you reduce the tidal volume. Okay. For adult patients, about 200 to 250 sufficient. Oxygen saturation target is about 86% to 90%. PO2 around 55 is acceptable, 55 to 60. There are various causes of hypoxemia. The oxygenator is maybe failing, maybe your flow is not sufficient, maybe the patient is febrile, is struggling, his oxygen consumption has gone up, you need to sedate the patient. There may be recirculation in a VV ECMO. I'll explain to that a bit later. If the hemoglobin is low, you need to correct the oxygen carrying capacity. So what happens in recirculation? The two cannula are very close to each other. Is only venous cannula. They're close to each other. So the oxygenated blood and deoxygenated blood are mixing with each other. It's like a shunt in the heart. If you have a shunt in the heart, that's what happens, right? So that you need to take care of. I'll come to that north-south syndrome a bit later. Weaning from the VV ECMO. At the moment I'm discussing only VV. Weaning from the VV ECMO, well, you have to make sure that the lungs have recovered. That means PO2, if your FiO2, you start back to full ventilation and your 100% oxygen FiO2, your PO2 should be more than 220, 225. Then slowly you reduce your flow, you reduce the oxygen in the sweep gas flow, and patient should be able to maintain at least for half an hour to 1 hour. You can put it at a very low flow to keep the circulation going, but oxygenation is primarily through the ventilator. If the patient is tolerating well, you can take the cannulas out. Coming to the VA ECMO, as I already said, you drain from the venous blood and you put oxygenated blood back into the arterial circulation under pressure. So basically cardiogenic shock is what it is used for. Pulmonary hypertension, right heart failure, myocarditis, maybe viral myocarditis, post-pregnancy myocarditis, and bridge to decision or bridge to transplant while you are waiting for an organ. So VA ECMO also can be peripheral or central. Central is done when you do cardiac surgery, the chest is open, so you put a venous cannula into the right atrium and IVC, and the aortic cannula, arterial cannula into the aorta directly. So when a patient is not able to come off bypass, that is what we do and bring the patient out. Peripheral is put into the femoral artery and femoral vein. So the arterial cannula remains in the descending aorta, and the venous cannula can be anywhere into the RA. These are the different cannulation sites. In children, you do axillary also. You can do common carotid artery. Okay. One thing must remember in VA ECMO is when you have peripheral adult VA ECMO, your cannula is into the femoral artery and femoral vein. So the peripheral distal perfusion of the limb suffers because the cannula is too big. So you must put a distal perfusion cannula. Okay. So that oxygenated blood is taken from the arterial line and put into the distal femoral artery. So the limb is perfused. Initial setting, again, as said, flow should be 60 to 80. Map of 55 to 60 is good enough. You measure the inlet and outlet pressures also of the oxygenator. The gradient should not be more than 50. And then you titrate according to your blood gases. Okay, now what does it do? If VA ECMO, what does it do to the right ventricular preload? It reduces it. Okay, it empties the right heart and the left heart both, so it will give rest to the ventricles. Afterload, it is unpredictable. So PA pressure is what happens. Left ventricular preload is reduced. Left ventricle is emptier. Okay, so you are giving rest to the left ventricle. Subendocardial perfusion will get better. Left ventricular afterload is increased because the blood is being pumped under pressure into the aorta. Coronary perfusion generally gets better. Paradox is VA ECMO increase the left ventricular afterload. Because of that, your pulsatility may be affected. Your aortic valve may dilate. Your left ventricle may dilate. Now, this is the north side Harlequin syndrome I was talking about. What happens in the VA ECMO is patient's heart is still working, patient's lungs are still working, but not that well. So partly deoxygenated blood is being pumped by the heart, left heart, into the ascending aorta, while fully oxygenated blood is being pumped by your ECMO machine into the femoral and lower aorta. So there will be some degree of mixing of it. If this is too much, this flow, then what will it do? It will distend the heart. It can distend the heart. If this flow is more, then what happens? This is not that well oxygenated blood. So this partially deoxygenated blood is going to the right carotid, ascending aorta, right carotid to the brain. So the right arm and brain would be getting deoxygenated blood while the rest of the body will be getting oxygenated blood. So right arm and the head can be cyanosed while the lower part of the body is nicely pink. So this is called the classical Harlequin syndrome or north-south syndrome it's called. And it happens only in VA ECMO. It will not happen in VV. Okay, that you need to remember. So pulsatility can be also lost. If your flow is too high, then the heart will not be able to pump too much because the afterload is increased. So there should be about 10, 20, 15 millimeters of pulsatility on the arterial trace. So that you should keep it in mind. What does one do if the pulsatility is lost? So you can give inotropes or vasodilators. Intra-aortic balloon pump is the commonest thing for VA ECMO to give. And basically you need to decompress the heart because if the left heart distends because of aortic regurgitation, because under pressure you are pumping blood into the aorta, left heart distends, it will make your ischemia worse. So sometimes as a final atrial balloon septostomy can be done. And if you are on a VV ECMO, then you can convert it to VAV ECMO. So decompress the heart. So avoid unnecessary high flow, avoid too much of oxygenation, avoid left ventricular distension, minimize your inotropes and vasoconstrictors once you are on full flow, adjust your ventilator setting and decompress left ventricle if it is distending. Now troubleshooting, I think the time is too short to get into troubleshooting. My next speaker is already here, getting restless. So troubleshooting, I can't go through that. I'll have to be called again to talk about that. But weaning, basically the heart function should be recovering. That means your inotropes should be minimal. Your heart starts ejecting, so you start seeing pulsatility on the arterial trace. Slowly start reducing your pump rate, the flow, and then once it is down to about 1 liter or so, that means the heart is ready to take off. You can put it on a standby or a low flow technique, and then later on. So patient should be conscious, other factors should have recovered, other organs should be functioning well, and the heart function should be recovering. What are the complications? Well, complications of inserting the lines, because these are invasive lines, bleeding, aortic dissections, and hematomas. Obviously, these patients are fully on anticoagulation. ACT you maintain about 180, so there can be hemorrhagic complications. So they require blood and blood products regularly and monitoring. Longer you leave any lines in, more the possibility of sepsis. So thrombocytopenia, other organ dysfunction, sepsis, strokes, because they are anticoagulated. These are the complications which you commonly see. And if the ACT is not high enough, then thrombus formation and then embolic events can also have to be kept in mind. So as you can see here, complications actually more in a VA ECMO than VV ECMO because higher anticoagulation is required. Hemolysis, thrombocytopenia more in VA ECMO than VE ECMO. These are the percentages in the also database. Infection is VA also is slightly more than VV. Limb ischemia, obviously VA ECMO would be higher limb ischemia. Bleeding complications, well, stop anticoagulation and then you compress wherever is bleeding from, stop anticoagulation, transfuse platelets if they are too low, apply obviously local compression, hemostatic agents can be done. One problem with ECMO is also PK challenges. Pharmacokinetic, very little is understood about the blood levels of the drugs. So antibiotics, what to give, what happens to them. So therapeutic drug monitoring is normally recommended. But facilities are not available in India. Initial loading dose should remain the same, but you have to keep it in mind that clearance may be initially increased, volume of distribution is increased, and some degree of adsorption may happen of the antibiotics in the circuit. Nosocomial infection, most of the studies have shown significant nosocomial infection worldwide in different parts of the world. Longer you keep it in, more the chances of sepsis happening. Longer you leave it, as I said, 6% for patients 1 week or less and 15% for patients suffer for more than 2 weeks, 1 to 2 weeks. Almost 30% when it's more than 2 weeks of sepsis. More so in VA ECMO, chest is open, it's more so. ECPR, when you do patient put on ECMO while doing CPR, that's also becoming very possible, probably India not so much, but in the West it is increasing. Sepsis is much higher. Organisms, well, Staph aureus is commonest organism. Candida is also happens significant, and then commonest the other ones, gram-negative sepsis, which you see. Prophylactic antibiotics, most of the people say, oh, don't give. Also recommendations, don't give. But also itself, there is a survey, most of them gave. But basically, you require it for a couple of days while a surgical procedure. So give it for 2-3 shots, and then you need to give antibiotic not for the ECMO, but for whatever disease the patient has, and for that if you require it. Coming to ECCO, well, basically what you do is, primarily, if it's only a carbon dioxide removal is a problem, oxygenation is not a problem, heart is not a problem, then you just need to do something to remove the carbon dioxide. So it's a technique which removes basically only the carbon dioxide. It's similar to ECMO, but the advantage is you require less anticoagulation and it's less traumatic because the flows are much less. So it's much less invasive. So what does one do? As you can see, you can drain the blood through venous line. Again, it goes through the pump, oxygenator, and back into the circulation, but to the venous circulation only. So what does it do? It gives respiratory rate, carbon dioxide is removed, acidosis is corrected, you can rest the lungs, and you need not put the patient on a full ECMO. Also, you can give some lung protective ventilation because for carbon dioxide removal is done by ECCO. So you can give a low tidal volume ventilation till the lungs are improved. So normally blood flow is only, as I said, 10 to 15, 25% of cardiac output, and it can match 50% of ventilatory demands from the point of view of carbon dioxide. Lowers hypocapnia, corrects acidosis, and pump-free configuration also has been used. Patient's own arterial pressure is being used to drive it through the oxygenator. So these are the various combinations. It may be incorporated together, the pump and the oxygenator, or it may be two separate ones. It's quite simple to use. Complications are similar while inserting the lines, and mechanical complications, pump failure can happen. Indications primarily is COPD. Patients who have NIV failure, before you put the patient on ECMO, you can try this. So your target pH is 7.3 to 7.35, respiratory rate 20 to 25, PCO2 reduction should be 10 to 20%. Obviously, it is used in ARDS also. So to meet your ARDS network in order to achieve your normal capnia. So this is what the circuit looks like. It's a sort of a dialysis machine here, and you have one cannula. It drains venous line through the oxygenator, and if you have a dialysis going, it will pump through the hemofilter, and then you can just connect it to the hemofilter. So this is one of our own patients on ECMO, you can see. So these are the line coming from there, it goes to the pump here. Now this is the hemofilter for dialysis, CRRT. So this is the inlet, outlet, goes to, from here it goes to the oxygenator here. This is the oxygenator. You take the oxygen from your flow meter, and that is attached here to blow off the carbon dioxide, and outlet from this goes back to the patient. This is the side view of the same thing. It's quite simple to use, less traumatic to the brain. So thank you very much for your attention. You have any question answer, or yeah? If anybody has any questions, you're welcome to ask. Yes, please. Yeah. Between the pre-membrane pressure and the post-membrane should be 50 mm. Should not be more than that. Should be more than that. Should not be. Should not be. And is it the same pressure that the cannula shows in the monitor? Like in P1 is the drying pressure? No, it will be different. It is different. So your arterial trace would be different. Your patient's pressure would be different, and these two are different. And how do we monitor this pressure? Can we have any monitor? You don't need really a trace, but you can record most of the monitors now record 4 pressures. There is no problem. You get a digital readout. Thank you very much.
Thank you so much, sir.